everyone. I'm Barbara Ham-Lee. We hope you and your family are doing well and are safe, and we thank you for washing your hands, wearing a mask when in public places, and staying home. The best thing all of us can do to help prevent the spread of coronavirus. On this edition of Another View, we ask the question, why are African Americans dying from COVID-19 at such an alarming rate? And what do the numbers tell us about racism and inequity in our healthcare system and beyond? We hear from doctors on the front line. Stay tuned. Another View will be right back after this news from NPR.
Discussing today's topics from an African American perspective. This is Another View.
Good afternoon, everyone, and welcome to Another View. I'm Barbara Ham-Lee. Thank you so much for joining us this afternoon, and we hope you are safe and well and staying home. So the numbers are frightening, particularly in the South. African Americans are dying from COVID-19 at disproportionate rates compared to other races. For example, in Louisiana, blacks make up 33% of the population, but 70% of the coronavirus deaths. In Alabama, they make up 26% of the population, but 44% of deaths. And it's not only in the South. Cities like Chicago, Detroit, and Milwaukee also have very high numbers. In Virginia, Governor Northam has asked state health departments to start reporting the number of deaths by race and ethnicity. Right now, they collect demographic information only on those who are infected. And that's spotty depending on who's testing and where. So why is this happening? My guests today have some thoughts, and they are on the front lines of this pandemic. Please welcome to Another View Dr. Thomas Levice, Dean and Professor and Weatherhead Presidential Chair at Health Equity at Tulane University School of Public Health and Tropical Medicine in New Orleans. And he's also the creator of the documentary, The Skin You're In. Dr. Levice, you have a long title. How are you?
I'm doing great, Barbara. It's always great to talk to you. They say the longer your title, the less power you have.
We'll see about that. Also joining us is Dr. Joni Claville. She's an ER physician in Shreveport, Louisiana. Dr. Claville, how are you?
I am doing well, Barbara. I thank you so much for the opportunity, and I look forward to this conversation.
Absolutely. Thank you for being with us. And Glenn Oder, Executive Director of the Fort Monroe Authority and its newly formed National Center for Freedom at Fort Monroe. How are you doing, Glenn? It's good to have you back.
We're doing fine, Barbara. I hope you and your family are doing well also.
Thank you. Thank you so much. So I want to start with you, Dr. Levice, because last night I was on a nationwide conference call with the National NAACP and Black Entertainment Television, and they were talking about the impact of coronavirus on the Black community. And the head of the American Medical Association said that while New York is the epicenter of the pandemic, St. John's Parish in Louisiana is the epicenter of deaths from this disease. Do you agree with that assessment?
Well, I can certainly say that parish certainly does have a higher number proportion to the size of the population there in the parish. Mm-hmm. We do have a lot of deaths. And I do think that the South in general is where we're really going to see the worst statistics.
And why is it? Why is that?
I think in the South you have the perfect storm of a number of factors that come together. You have states, in most cases, you have states that refuse to expand Medicaid, so therefore you have more people that are uninsured than otherwise would be. You also have right-to-work states, so you have no union protection for workers. You also have states with lower minimum wage, so you have more people in poverty than necessary. And poverty people in poverty have a difficult time mitigating something like this. They don't have occupations that allow them to work at home on Zoom and still be paid.
Mm-hmm. And so you talk about all these other factors, and your work is very much about social determinants and how they affect our health. Because everything that you mentioned had nothing to do specifically with coronavirus, yet this is the population that's being affected the most.
Yeah, well, I think that's right. Is that people that are most vulnerable are put in positions that are being put in a position that they just don't have the resources to mitigate against. Now, you have to also take into consideration that the South is we call the South the stroke belt because of high rates of chronic conditions that we've all determined places you at increased risk of mortality if you are infected: hypertension, heart disease, cancer, diabetes, asthma, COPD, things like that. So all of those things are here in spades. I would add one other thing is that you also have a lot of rural areas here in the South. What we've done as a nation, we've decided to put prisons in rural areas. Prisons and other congregate living arrangements like that are perfect places for viruses like this to spread. And so those prisons are in rural areas. The people who work in the prison tend to be people who live in those prisons. And if you have outbreaks in these smaller counties or parishes in the rural areas, you have hospitals that typically don't have the resources to handle the patient flow.
Right. Dr. Claville, and doing my research and in reading and trying to understand all of this, particularly how this disease is affecting the African American community, I am dismayed at the amount of time, airtime as well as print time, that is spent on blaming the African American community because of things like high blood pressure and diabetes, asthma, etc., and saying, well, if you had taken care of yourself, you wouldn't be dealing with this.
Well, this kind of dialogue has really been something that we've seen time in, time out from our Surgeon General. We've seen it, and it's really upsetting because, just like Dr. Levy said, today's disparities flow directly from our past. And African Americans are overrepresented in a lot of service sectors and service sector jobs. So we are economically disadvantaged in a lot of ways. So a lot of times what happens, and what I see in the emergency department, is people have to, with their economic conditions, they have to choose between sometimes paying rent or paying a doctor's bill, or using the gas money that they have to go to work versus getting the prescription that I just wrote for them in the emergency department. So that translates to me in the emergency department. A lot of times, I'm the primary care physician for these patients, and do I think that African Americans are disproportionately affected by hypertension and so on and so forth? I don't think that we are affected disproportionately, but I think that we bear the brunt of the being untreated or not having access. So therefore, when we don't have access, we don't treat, and the conditions get worse. So
go ahead.
So that's where I am. I think that this is what we're dealing with.
So what's a typical day for you when, in light of coronavirus, since this has been happening, what is your day like as an ER doctor?
So I think about my life, a typical day in the emergency department before Corona, BC, before COVID, working in a 20-plus bed emergency department that sees approximately 55 to 58,000 patients a year, with a vast array of conditions ranging from appendicitis to severe trauma, heart attacks, head injuries, hyperglycemia, respiratory failure, kidney failure, to now a typical day for me walking into the emergency department is anything but typical. Now, our volumes are lower than we've traditionally seen because people are trying to adhere to the stay-home order issued in Louisiana on March 22nd this year, and it's extended to April 30th up to this time. But it appears that the level of illness, even though the people are adhering and attempting to adhere to the stay-at-home order, it appears that the level of illness is much higher. So that translates to the patients who do actually arrive in the ER are now much sicker. So while our volume has decreased, we're not seeing a tapering off by any means and as it pertains to the level of acuity and how busy we actually are in the ER. So we're seeing less patients in the ER, but they are sicker now than they ever have been.
So are they still coming in for any of those types of conditions that you talked about, or are you seeing more COVID-19 patients now?
Well, currently what we're seeing, and I've talked to colleagues from, I trained in South Louisiana. I trained in the New Orleans, Baton Rouge area, and I've worked in emergency departments all along the I-10 corridor and I-49 corridor. And so I've seen, I have connections with people here and there. And basically what we're seeing and the conversations that we're having, we're still seeing heart attacks. We're still seeing strokes, but we're not seeing them at the level that we used to see them. And I think that people are staying at home with these illnesses. So what we are seeing, unfortunately, is a stroke that happened 3 or 4 days ago. And now the family members are saying, well, Mom was talking, but she hasn't talked in 3 days. So we just thought it was imperative that we bring her in. And we're seeing a delay in treatment and a delay in recognition because people are now afraid to come, or they are making every effort to adhere to the stay-at-home order.
Right. Dr. Levice, I know you can only stay with us for a short time, so I want to pivot back to you for just a moment. What lessons or what do you think will happen in terms of once we get through this pandemic? What are you hoping that we will truly pay attention to in terms of the social determinants and all of that and the health inequities in our system so that we can start to make a difference? What can we do? What do we need to pay attention to in terms of once this is done, how do we make it better?
Well, I mean, I think first of all, we certainly need universal access to health care, and I think that doesn't happen as long as we have this employer-based health insurance system. I mean, I think that what we're seeing is that the system that we have in place is just incapable of handling something like this. You know, even with the Affordable Care Act and the expansion of Medicaid, you know, we've adopted policies that people that are illegally in the country, undocumented, are not able to participate in those programs. And of course, a viral infection is completely unconcerned about whether or not you have a health insurance card. So if you get in the elevator with someone who is infected and they're undocumented, your insurance card is not going to help you. So we need to be more thoughtful in our policy making. We also need to look at our the economies and how our economies are set up. Here in New Orleans, we have a very an economy that has a lack of diversity. It's only based on tourism. And tourism, by nature of the jobs in tourism, people are working on tips with very low minimum wages. People come to this city from all over the world. So the workers in the tourism industry are disproportionately African Americans here, and they're at greater risk. And that's why I think it's a little early for us to go beyond that. I think because we need to understand more specifically what is the nature of this racial disparity. And I think, you know, the narrative that African Americans are dying because of higher rates of chronic conditions is a comfortable narrative, but I think that there's more complexity to it than just that. Here in the South, white Americans have extremely high rates of all of those chronic conditions also. So it's not just the chronic conditions. The other thing I think it's important to understand about data is that the statistics, the 70% deaths among African Americans in Louisiana, while we're only 32% of the state population, the bulk of the cases, the COVID cases, have been in the New Orleans area, which is 58% African American. So the disparity is not quite as bad as it might seem when you bring it up to the state level. And the other thing that I would add is that because we don't have a national strategy and a regime on testing, we don't know how many people are infected. So therefore, how many people are at risk. It might be that 70% of the people who are infected are African American. And I think when you look at the occupations that we work in, it would not surprise me at all if 70% of the infected people in Louisiana are African American, in which case, if 70% of the deaths are African American, then that would be consistent with an infection rate of 70%.
What are you concerned for yourself? What are you doing on a personal level in terms of trying to stay safe?
Well, I'm adhering to all of the. So I'm part of the team that's looking at what advice we want to give people, and not only have I been trying to give good advice, I've tried to model that advice. So early on, when the Surgeon General and the President was saying, "Don't purchase masks," back in February, which I thought was a reckless advice to give. I've been wearing masks since then, because I think any mask, whether that mask would protect you against the virus or not, wearing a mask is better than not wearing a mask. Any mask is better than no mask, because the mask will remind you not to put your hands on your face. The mask will remind you not to put your fingers in your mouth or in your nose, which is in many cases the way the virus gets into your body. And wearing that mask will model to other people around you that we are in the middle of a pandemic and that you need to take it seriously. So I think anyone who is still suggesting that we shouldn't wear masks is just being reckless. So that's one thing that I do. Wash my hands constantly, and I think that is better than using the alcohol hand
sanitizer.
Better than using the hand sanitizers. So I do that. I stay home as much as possible, and I do try to observe physical distancing, not social distancing, which to me is a perfect example of the lack of quality health communications, because we don't want social distance. We want physical distance. We need social connectedness if we're going to make it through this.
So when the Surgeon General says things like, hey, Black community, stop drinking, smoking, and I can't remember what the third thing was, in that sentence, that's more harmful than helpful.
It's harmful, and it's harmful on many levels, and it's harmful because it further degrades trust in the quality of leadership that we have. And when I heard that, I had already begun to wonder about the quality of the leadership, but when I heard that, it just led me to conclude that we really can't rely on what the federal government is telling us. Fortunately, we have a federalist system in this country, and we have several states where we have governors that have done an excellent job of providing leadership, including here in Louisiana.
So my last question to you, and then we're going to let you go so that you can get to your other responsibilities. But what do you say when you hear people within our community, the African American community, still saying, we can't get this? This is not our disease. This is somebody else's disease.
Yeah, well, you have to understand where that comes from. The African Americans, in general, of course, I'm making a generalization, so it's not everybody. But
sure.
Disproportionately, African Americans have distrust for this country and leadership in this country. We have 401 years of experience that tells us that distrust is logical. It's rational. And so we as leaders, healthcare leaders, have to understand that distrust comes from a very logical and rational place on the basis of 4 centuries of untrustworthy behavior towards us, right? So we're going to be distrustful. So we have to find ways to message to African Americans in ways that they will hear it. And what you do is you point out to them, 70% of the deaths are African American. If you're still believing that African Americans somehow are immune, to this virus, then I don't know what else we can say to people.
Well, hopefully programs like today's show will help remind them yet again that this is very serious and that it does affect our community just like everyone else. Thank you so much, Dr. Thomas Levice, Dean and Professor at Tulane University School of Public Health and Tropical Medicine in New Orleans. Please stay safe, and we appreciate you being with us.
Thank you.
All righty. You take care. And I want to bring Glenn Oder into the conversation. Glenn, because as Dr. Levice was just talking about and Dr. Claville mentioned, there is a historical perspective to all of this.
Yeah, that was an excellent segue. I really appreciated his comment there. Fort Monroe is, as it was identified by Senator Mark Warner one time, he said, Fort Monroe may be the most significant site in our country for African Americans. Located here on the coast of Virginia, where in 1619, the first landing of Africans occurred here at Point Comfort and tragically traded as property. And then, the history of the fort is that we actually have learned that the fort was built by enslaved labor. And then, at the outbreak of the Civil War, 3 men escaped and came to that very fortress and were received into the fortress. And the next day, when the Confederates came to get them back, they were not returned as property, and they were kept, thus, launching this towards emancipation. It's a historic site, and it fits very well in today's narrative. We actually have recently learned that the first contraband hospital, or at least what we believe to be the first contraband hospital, was actually built here at Fort Monroe. It stands to reason, if this is where the first contrabands were, that the first hospital would be here. Imagine finding the first hospital where, for the first time, African Americans were not treated as property. We've also learned that Harriet Tubman was assigned here as the matron of the Colored Hospital at Fort Monroe for a period of time. So very quickly, we have the history, Barbara. We have the resources. You've used them. We have a place here where we have theaters and we have a visitor center. We have outdoor programs where we can actually bring people to Fort Monroe and use these resources. And now we have this initiative that we've launched with Huntington Ingalls is receiving the shipyard's community transformational grant. We have what we call the National Center for Freedom, or our aspirational goal for the National Center for Freedom at Fort Monroe, a place where we can host these discussions, a place where we can bring our community together. And this is all coming together at this amazing time, and that's why we're on the show today, is we want to let people know Fort Monroe wants to be part of this conversation. We're concerned, we want to learn more, and we want to educate people.
Yeah, and Glenn, I'm glad to hear you say that, because I have had lots of eye rolls, especially when we talk about how the coronavirus and COVID-19 is affecting the African American community, because it's kind of this feeling of, oh, here we go again, there they go complaining. And you say that Fort Monroe is a safe space for us to come together and really talk about some pretty tough issues that that divide us right now, as opposed to bringing us together.
Absolutely. This is, and we've done it. You and I have done it. We've done it with universities that we partnered with when we hosted events here. And it's interesting. Fort Monroe is a place. I talked with a black minister one time, and I talked to him about making this a safe place, for how these conversations. And he said, no, Glenn. He says, we need to empower people. We need to create a place where people feel strong enough. And the way you do that is through education. And when people get educated, then they get emboldened because they have the facts. And that's what's so exciting about the programs, which you've helped host at Fort Monroe, and where Fort Monroe wants to do more of those.
Absolutely. So we will have to keep moving forward. What are your plans at this point in time? Are there any programs planned right now that we can come together on?
Well, right now our plan is to keep everybody safe.
Yes.
So that's the highest priority. The priority is to keep everybody employed, and so we're working hard on that. But we're trying to take the information that we have at Fort Monroe, and we're trying to consolidate that. We're trying to find ways to move that onto online programs. We are preparing with this grant for the National Center for Freedom that we got from Huntington Ingalls. We are preparing to have some lectures that would actually be online, and we'll be advertising those. But we also want to be ready when this is over. We think people are going to want to come to Fort Monroe. We think they're going to be outside. They're going to be here. And so we're putting up signs to tell people about the history of Fort Monroe so that they'll be educated. And we also want to use these resources that we have so that we can host more programs and deal with this lack of understanding about disparity and how it affects everything. We're talking about healthcare today, but this freedom reaches across every segment of from employment to healthcare to religion. We need to use Fort Monroe as this place where people can come together and find out what does it mean to be free in a democracy today.
Absolutely. And that's a big conversation. 440-2665 or 1-800-940-2240 are the numbers to call to join our conversation. What questions do you have for Dr. Joni Claville? She's an ER doctor in Shreveport, Louisiana, or for Glenn Oder to talk about Fort Monroe and its role in helping us as we move forward through this pandemic to be able to come together as a people. 440-2665 or 1-800-940-2240. And if you're just joining us, we're talking about the coronavirus pandemic and its disproportionate impact upon the Black community with Dr. Joni Claville, an ER doctor in Shreveport, Louisiana, and Glenn Oder, Executive Director of the Fort Monroe Authority and its newly formed National Center for Freedom at Fort Monroe. And earlier in the broadcast, we were joined by Dr. Thomas Levis, Dean and Professor at Tulane University School of Public Health and Tropical Medicine. Dr. Claville, what are you doing in terms of your own personal safety? We see all the stories about lack of PPEs, personal protection equipment, and so forth. And I know you have a beautiful family. Are you going home in the evenings? Are you separating?
Well, what I am doing, Barbara, actually, I have a protocol. So when I go to work, I follow a protocol, and when I come home, I follow a protocol. So basically, what I am doing when I get home from work, before my family even sees me, I completely undress in the garage, and my clothes go into the washer, and they get washed. I shower, because I am a wife and I am a mother, and I have what I've seen, and in terms of physically distancing from my family during a time like this. My husband and my children, they are my sanity, and I hold them to be very dear, and they make all of this worth it for me. So what do I do? I have healthcare professionals. We are we are knee deep, waist deep, chest deep in this pandemic, and we're absolutely doing the best we can with what we have to work with. I have physician colleagues all over the state. Some of them are staying in hotels. Some of them are in Airbnbs. Some of them are staying with other fellow physicians, because they are absolutely terrified of going home to their families for fear of being unknown carriers or being in the, quote, incubation period of the disease and unknowingly bringing the disease to their families. So personally, as a wife, a mom, having parents and grandparents who are in high-risk groups, and recently having a family member to die 3 weeks ago with coronavirus, I understand on both sides of things. So I am physically distancing. I avoid large events, mass gatherings, avoiding close contact, because what we do, what people, there are a lot of protocols that people follow. You go to a store, you go to a business, and they check your temperature and see if you're febrile or not. Well, the studies are showing that 25 to 50% of the coronavirus carriers don't have one symptom. So there are people that are asymptomatic carriers that feel, hey, I feel fine. I'm doing well. I feel fine. And they are carrying and are carriers of coronavirus to others that may be in these high-risk groups. So I'm distancing myself. I am also washing my hands often.
Yeah.
Soap and water. And the study shows, hey, 20 seconds, do about 20 seconds of hand washing, and to cover your mouth and your nose with an elbow or a tissue when you cough or sneeze, and then throw that tissue away. Avoid touching your eyes, nose, and mouth. And clean and disinfect surfaces that you touch.
Yeah. Are you Dr.
So
Pavil.
those are the things I'm doing. I'm sorry.
Yeah, no, that's okay. So, I got to ask this question. Are you afraid?
I am cautious. I am
Okay.
prayerful. And with what is happening and looking at the numbers, I can't say, Barbara, that I have not been fearful at some point.
Wow.
But I am hopeful we will get through this. And what I do know about the great state of Louisiana, the United States of America, and the world as we know it, we will never be the same after this.
Yeah.
But what I do know is that we are resilient and we will get through this.
Wow. And thank you for your honesty, because I think sometimes people think that because you're a doctor, you just, you don't have those emotions and those feelings too. And that's just not the case. So that's just incredibly awesome. 440-2665 or 1-800-940-2240. Dr. Kimberly Adams-Tuck joins us from Norfolk. How are you?
Oh, Barbara, I'm well. Thank you for all you've been doing.
Thank you.
I've been a little busy with my work in emerging and infectious diseases, but I wanted to take the time to call in and listen today. In fact, the main reason was I just wanted to listen. And then with listening, it just brought up some things in me. This whole language that we're using about disparity. I've been teaching about health and inequities and working in it, particularly in HIV, for about 20, 25 years.
Mm-hmm.
And so I was listening, and I'm the folks you've had in from New Orleans, how on target they are. And this is a grand opportunity for us to do something about health policy in this country. Yet at the same time, we continue to use racialized and not so positive language in the United States. So every time I hear health disparity, the hackles on my back just rise, Barbara.
Okay. So how would you describe it?
Well, disparity says that there's something inherently different. And there's nothing inherently different about African Americans. We do have a common history and experience and ethnicity that maybe we have more commonalities related to risk for certain chronic diseases, but there is nothing inherently different or unequal about us. So disparity is not the correct word. And more progressive countries, it's always spoke of health inequalities and health inequities.
Okay.
When I teach about it, where American public is not ready for that language, so I often don't go all the way to inequality, but I'll use inequity because people don't quite know what that means, and you have to explain it. But this disparity language that started in around 2003, which was a great thing, the text was unequal treatment. That's where all this started from, the Institute of Medicine at that time.
So how would you describe, so that our audience understands, how do you define then inequity as opposed to disparity?
So we don't all start at the same place, but it's not biological.
Gotcha.
It's not physical. What it is it's structural. It's the structural differences that take place in our country related to different folks. And so because of those structural differences and inequities, we're not all starting at the same place.
I see.
And yes, and your speaker who spoke about the rates of chronic disease, whether they're diabetes. Last night on your station, wonderful work, Blood Sugar Rising, about the diabetes epidemic, or really pandemic in the United States.
That was on Channel 15, WHRO TV 15. Yes.
Absolutamente, yes. And so he is so right that there is not a whole lot of difference in chronic diseases, but it's the outcomes and the access that people have and opportunities that people have. So what we're talking about, we have to differentiate. There's health. We put it all in the same umbrella. There are health care. You could say disparities, but health care inequities and inequalities. And then there are health inequities, which are the outcomes. because
Gotcha.
of the differences. That's what unequal treatment was all about. That tomb on the state of treatment for different kind of folks in our country.
Okay.
It was all about, it's the treatment, it's the care that leads to the different health outcomes, which we call health disparities, but it's not really, we have to back it up with health care.
All right. I got it. Dr. Kimberly Adams-Tuss, thank you so much for calling in, and thank you so much for listening. Dr. Claville, do you want to add anything to that conversation?
Well, I echo exactly what she said. I mean, what happens is, what I see in the emergency department is hypertension in the Black community and the white community. It's hypertension is hypertension.
Mm-hmm.
Heart disease is heart disease in the Black community and the white community. But what I read an article, and it was so profound. But and I want to share something that I experienced in medical school, and my brother-in-law, he speaks about it all the time. I was in medical school in New Orleans, and there was a young man that came in, and he broke his foot,
Mm-hmm.
and so basically we're looking at X-rays and determining what bones were broken, so on and so forth. And out of the blue, a counterpart or a colleague that was not African American said, just and plainly and openly, as if it were acceptable, that the classmate said, you know, he probably broke his foot stealing someone's television.
Oh my gosh.
Oh yes. Oh, yes.
That's where the bias comes in.
Yeah. So this is where these kinds of things stem from. And can you imagine what kind of care this person is providing 10, 15 years, 20 years down the road because of innately the bias that they have.
Mm-hmm. The implicit as well as the explicit bias. Yeah.
So what we understand about all of this is race still shapes personhood. It marks the boundaries of, hey, do you deserve this or do you not deserve this? And basically, in other words, we say, well, who deserves, when we talk about saving lives with corona, what lives are you talking about when African Americans are 70% of the deaths? What lives are you talking about?
So in your ER, then who's being tested? Is everybody tested who comes through, or there's certain? What's the criteria?
No, initially the criteria, to be perfectly honest, the way when coronavirus, when we started addressing coronavirus, the first case in the U.S. occurred we saw a first case in the U.S. and we started the alerts went off, and then we get memos every day that say, well, hey, you are. Initially, we were testing people that had fever, cough,
Mm-hmm.
general malaise, or people that had traveled and were had traveled or had recently been exposed to people that were in these target countries. And so day by day, these things have changed. We've gotten memos that say, well, hey, maybe, still the person needs to have a fever and a cough and so on and so forth. When I expressed to you previously that a lot of these, you're talking 25 to 50% of people are asymptomatic.
Mm.
So right now, at this point, and this is months down the road, and more accessibility to test kits, because at first we were really being strategic about who we test because we were limited on test kits.
Right.
And so people had to almost meet hospitalization criteria or be in high-risk categories for us to test them. But now, the way we're treating people in the emergency department, you have COVID until proven otherwise. So that's what we have. That's my typical day in the emergency department when I walk in and assume patient care. I wash my hands. I gather my PPE. I gather my equipment. I wash my hands again. I put my gown on.
Do you guys have enough equipment? Do you have enough equipment at your hospital?
At my facility, we do.
Okay.
We do have protocols where we do reuse some equipment in an effort to save and or not waste anything. But we do have enough equipment at this particular time. Now, I do have colleagues that are in. One particular colleague is in Baton Rouge at one of the main hospitals in Baton Rouge, and her medical staff told her that, hey, unless you do not, as a physician, get an N95 mask, unless the patient has been proven to have coronavirus. Well, by that time, you know what? It's too late.
Wow. Let me see if I can get one more call in before we have to wrap things up. Maureen joins us from Virginia Beach. Hi, Maureen. You're on the air.
Hi. I just wanted to say that in regards to the disparity between the treatment of blacks and whites, Wanda Sykes had a very good rant on the Surgeon General's comments about the differences. And in her case, she was sent home from the hospital after a double mastectomy with ibuprofen as her painkiller. And I think that's disgraceful and shouldn't have happened to anybody at all. But it's because of the myth that blacks don't feel pain in the same way that whites do, which is an absolutely ridiculous myth. And I just can't believe that in this day and age, a so-called doctor still believes that.
Thanks, Maureen, for the call. We appreciate that. Dr. Claville, there are a lot of myths. There are a lot of implicit as well as explicit biases that go into the medical care. But as we wrap up with our last 5 minutes, what is the one lesson that you would like to leave, particularly with the African American community, about how we should navigate our way through this pandemic?
Well, what we do, and thank you, Maureen, for the comment and the call. To make sure our loved ones are receiving the best care possible, like I said previously, in the healthcare community, we are doing the best we can with what we have and what we've been given. But I'd like to add, and I'd like to interject this at the end. So basically, we will understand and we can have these conversations with our doctors, with the people that are taking care of our loved ones that do have coronavirus. Mm-hmm. Basically, what I am seeing in the emergency department is this, and I've never seen this before, but coronavirus, this is different. What I'll have patients to come into the emergency department, and they will tell me, I've been having symptoms for 2, 3, or 4 days, and I'm just not feeling well. And what we do, we get vitals on patients when they come in the emergency department. So those vitals include a blood pressure, a pulse, a temperature, and we also put a device on the patient's finger and or ear. It's called a pulse oximetry and a pulse oximeter. And basically, it measures the percentage of blood that the patient is saturated, the percentage of blood that is saturated with oxygen in the body. Okay, we're almost out of time, so we got to wrap it up. Get to what you want us to be able to say to our doctors, or what should we be paying particular attention to? What we do know about coronavirus now that we did not know 1 month ago is that all the patients that come into the emergency department that are oxygenating 50, 60, 70%, they all do not belong on ventilators. The problem is that 86% of the people, the studies show that 86% of the people that end up on a ventilator will die. So what are we doing? What have we seen is that we have other methods to use in the emergency department, in the hospitals, that can bridge people, that give them a better chance of survival. And that is high flow oxygen, that's BiPAP and CPAP. Those are things that were recently used on Boris Johnson and other people alike, that kept them and bridged them out of the ICU and back home. So I just want people to understand that because the oxygen level, I have seen people with an oxygen level of 50% in the emergency department with coronavirus, and they're talking on their cell phone.
Wow.
That's what I'm telling you, and that is unlike anything that we've ever seen.
Okay.
So what I'm saying, that's what I'm saying. Everybody should not be placed on a ventilator emergently.
Okay, got you. Dr. Joni Claville, we will have you back again to continue this conversation. Thank you so much for joining us. And Glenn Oder, I want to give you the very last word, and that is, if people want to get together at Fort Monroe or to think about programs coming up, who do they call? Where do they go?
Well, I want to remind everybody, listen to our governor. We're very fortunate to have a doctor as a governor. Let's stay home, do what he says, but go on the website, look at our programs that we have on the website. We're going to be populating that. The staff is working hard to develop more and more information and more programs. Some of the stuff is really exciting. So go there, learn about our history, come to Fort Monroe when this is over, and let's have conversations that are going to give us all a better future.
Absolutely. Thank you so much. That's Glenn Oder, the Executive Director of the Fort Monroe Authority. Thank you very much for joining us. A lot of information. So this coronavirus pandemic is something that none of us has ever experienced, and the information overload, along with major disruption to our everyday lives, can be just completely overwhelming. But through all of it, there is hope. We welcome to Another View now Bishop Courtney McBath, Senior Founding Pastor of Calvary Revival Church in Norfolk and Presiding Bishop of Calvary Alliance of Churches and Ministries, the umbrella organization for ministries throughout the United States and abroad. Bishop McBath, thanks so much for joining us.
Oh, it is my pleasure, Barbara, and I have certainly enjoyed listening to you and the physicians, and Glenn, Dr. Leviste have really blessed, I think, all of us today.
Thank you. So what are you hearing from your congregation? What kinds of words of inspiration and hope can you give us? Because, some of this stuff is just so heavy, and I just don't want people to lose faith.
It's been overwhelming, to say the least. Some have said, Barbara, that we haven't seen anything like this since the days of Noah. That gives you some perspective.
Wow.
So where something penetrated every facet of life across the globe, every continent affected by it. We haven't seen anything like this since that time. And so I've thought a lot about, Barbara, you've heard of these folks, both fictional and factual prisoners who held on to a picture of a loved one or someone that they knew throughout their prison sentence in order to maintain hope. And I'm sure you probably have millions of stories like that. I thought of that myself, and I thought about that's a vision to help look beyond where you are. And I think one of the things, because the pandemic has such a sense of finality and there is so much death involved, that we have to literally tell ourselves that there is life beyond COVID-19. That we will return to a different life, to a better life, to a much more normal life. And then I've begun to just share 2 or 3 things that I think create a vision for the future. One of those is that the new normal after this is that we love people like we've loved them through this crisis. It's been so amazing to watch people love others, give to others, bless others. What if particularly in our community, we move to a different level of care in the community where once again the village worked together instead of being separated on so many levels?
Yes.
I think that kind of vision could change us. The idea of collaboration. and organizations working together. If we could get that as our new norm, Shakespeare once said that misery creates strange bedfellows, and pandemics do too. And I think if we could start working together and it not just happen now, but it become a new normal for us, that vision, I think, would give some hope even where we are right now.
Yes, absolutely. And I noticed that, I am assuming that you're performing services online along with, many churches across. But are you hopeful that this will help to increase people's faith ultimately?
This is our desire and our hope. Of course, more people are watching and listening and online now than ever before. People have two things. They have time on their hands and they are desperate. Those two things push people toward answers, and people are thinking about life. So if in the religious community, if we can provide real hope, real answers, and along with some practical steps like health issues, what will it look like in the new norm if we as a people take better care of ourselves and we stop looking for help to come from somewhere else and we start looking within for help? It changes everything. And I think if we can present that even now during COVID, that there is hope beyond this, there's change that could make us so much better, then I think that alone could help people just have enough hope to make it through one more day.
Bishop, don't you think that this is one more time, though, that shows the resilience of our people?
Oh, yes, ma'am. Absolutely. At every juncture, and now more than ever before, you see what people who've been through great oppression, what they rise up and are able to do. We've watched 5,000, 6,000 people get fed in our parking lot, and we've watched young people step out and become volunteers and make sure people are fed. And it's amazing to see this happen. And it does speak. It's a strong testimony of the resilience of our people and our ability to rise in moments of crisis. If we can now make that a part of our systemic way of life, so it's not just a response in crisis, but it becomes the way we do things, we can become something altogether different than we've ever been before.
Absolutely. Well, we thank you so much for coming on our show and giving us some words of encouragement and of hope, and to let folks know that, this is not the end, that we can keep pushing forward. And to those, what would you say very, very quickly to those who have lost a loved one through COVID-19?
We are praying for you. There are no simple words to make that pain go away, but we do know that God is comfort to those who are hurting. And so we're absolutely praying for those who are in loss, and for those who are living through this. Just remember that the person that dwells in the secret place of the Almighty abides under the peaceful shadow of our God, and He's going to watch over you and be your safety and your refuge and a source of strength for you, even during this season.
Thank you so much. That's Bishop Courtney McBath, Senior Founding Pastor of Calvary Revival Church in Norfolk and Presiding Bishop of Calvary Alliance of Churches and Ministries. Thank you so much for joining us. And thank all of you for doing all that you're doing to help stop the spread of COVID-19. Hang in there. We are truly all in this together. Please share this show with your family and friends. Go to anotherviewradio.org and download the podcast, and you can find the archive of all of our shows there. So join us there. Our theme music for Another View was composed and performed by Jay Sennett. And just so you know, we're practicing social distancing here at Another View. All of our guests joined us via phone, and the AV crew, producer Lisa Godley, audio engineer Todd Washburn, and call operator Victor Bowen, are 6 feet apart in the control room. I'm in the studio alone, physically alone, but never alone, because I have the privilege of talking to all of you. Please join me in saying happy birthday to our producer, Lisa Godley, and join us next Thursday at noon for Another View.